Hi everyone, and thank you for being here today. I'm Eva Dubin, and I'm the founder of the Dubin Breast Center. Thank you, thank you, thank you. It's a pleasure to be here today for our annual Fact versus Fiction Luncheon and Symposium. Today we have an esteemed panel of experts who are eager to separate the myths from the truth about breast cancer and women's health and answer all your questions. But first, I would like to say a few words about the Dubin Breast Center. The need for the center grows stronger every day. With approximately 200 patients seen per day coming to us from all walks of life. We remain committed to providing the most advanced breast cancer care to every person, regardless of financial circumstances. Our researchers are also engaged in important, groundbreaking work that is changing the way we diagnose, the way we treat, and the way we prevent breast cancer. I'm so proud of what the center has achieved since it opened 13 years ago. But I'm even more excited about what we can do to help women stay healthy for many, many more years to come. It's now my privilege to introduce our next speaker, Suzanne Foote. A mother to 7-month-old twins, Suzanne is a breast cancer survivor and a patient at the Dubin Breast Center. We are so grateful that she's here today to share her story. So please help me welcome Suzanne Foote.
Good afternoon, and thank you, Eva. Dr. Port and Dr. Welts invited me to speak today, which I really appreciate. But of course, the topic they asked me to touch on is both personal and really difficult. I don't usually mind taking on tough topics, but honestly, as a diehard Green Bay Packers fan, I'm not ready to talk about Aaron Rodgers coming to the New York Jets. So I'm gonna save that for another time. In fact, today I really want to speak about time. I've been thinking about time a lot recently. It's certainly our most valuable resource and our greatest gift. This was made especially true to me in 2019 when I was diagnosed with stage 1 breast cancer. There is no good time to get this kind of news, but for Mark and me, we've been married for less than a year. It was a tremendous shock, which reverberated further when we realized that cancer would be a hurdle in our quest to start a family. In every respect, from diagnosis on, time would be of the essence. With the support of my colleagues at Bloomberg Philanthropies, I was quickly connected to the Dubin Center and to Dr. Port. And there, I was immediately reassured I was going to be okay. Because in my 20s, I had found out that I'm a carrier of the PALB2 mutation and had been getting regular screenings, and so my cancer was caught very early. Even so, with Dr. Port and Dr. Sultan's guidance, I decided to have a bilateral mastectomy. It's not an easy recovery, but with their help and the help of my PT, Amy, I survived. And ultimately, I know the surgery was the right choice for me because it's given me a measure of peace of mind that I've done everything I can to limit my risk of reoccurrence. Dr. Port and Dr. Tiersten also recommended that I undergo IVF before I start hormone therapy. This not only gave me the best chance of getting pregnant after my recovery, but it also made it possible, catch this, to ensure that any future babies do not have the PALB2 mutation. It is amazing to consider how far medical knowledge has come in just a few years. And I personally have seen that in just a single generation. When I was 8, my beautiful, smart, and courageous mother Andrea Sykes-Foote, passed away, succumbing to her own fight with breast cancer. She was just 43 years old when her life was cut abruptly short. But what a life. With 3 young daughters, a very successful career as a lawyer, great friends, and a loving husband, she used her short time on earth so well. When I was diagnosed, of course, I thought so much about my mom, and I really tried to remember that the gift of time is not just about how many years you have, but of course how you use them. And my diagnosis really put into perspective how lucky I am to spend my family time with my amazing siblings and my dad and my wonderful stepmom, Kari, along with Mark and his amazing family, including his parents and sister. It also made me think about how fortunate I am to spend my professional time at Bloomberg Philanthropies, working with colleagues who help so many people around the world live longer and healthier lives, and who personally did everything they could to ensure I did the same during my cancer journey. And finally, even in my fear and uncertainty, I knew I was lucky to be spending time with the amazing doctors at the Dubin Center, where all your caregivers are in one place, and they do so much to coordinate your care so you don't have to do as much to get your medical team on one page. How lucky they felt to spend time with me, I really can't say. I am the type of patient that cries and faints before the needle even gets to the room. But even so, they never made me feel self-conscious or uncomfortable, always confident and cared for. And as a result of the time they spent, here I am enjoying the best time of my life. After making the decision with Dr. Tiersten that it would be safe to take a break from hormone therapy to get pregnant, on September 23rd, 2022, at Mount Sinai, our twins, Peter and Josephine, were born. They were 7 pounds, 1 ounce, I have to say this, and 7 pounds, 2 ounces, respectively. So that's 14 pounds of baby, for those doing the math. Jojo and Pete are turning 8 months tomorrow, and I'm still healthy and cancer-free, and I'm still thinking about time. Because as you can imagine, in an apartment with 2 8-month-olds, it's in very, very short supply. So in thinking about speaking today, time seemed like the right topic, because that's really what the Dubin Center is all about. Not only do they save patients like me time by ensuring that care from several amazing doctors and caregivers is coordinated, but Dr. Port and Dr. Tiersten and Dr. Welts and their talented colleagues, through their research and care, give time to so many people every day, including young moms or young women who want to become moms, who are given years and years of healthy time with their families because of the amazing care at Dubin. So on behalf of those moms and my mom, thank you for that time, Dubin, and thank you to everybody who made Peter and Josephine possible. Because of you, I currently have no free time, and I couldn't be happier about it. So thank you.
There is no time written in here for me to compose myself, so I'm going to have to do that as we go. Suzanne, thank you so much. It's such an honor to know you and to help care for you. Incredible women like you motivate us every day, every single day at the Dubin Breast Center, where we work tirelessly to make breakthroughs that improve the lives of our patients. Seeing you and others like you not only survive, but really live life to the fullest, really inspires us to push beyond what's possible and seek new and innovative ways to improve breast health. Thank you so much for sharing your amazing story and trusting us with your care. We're honored. And many thanks to all of you for joining us today. Before I continue, please feel free to enjoy your delicious lunch. I am Dr. Lisa Port, the director of the Dubin Breast Center, and I am so very pleased to be here once again for our Fact versus Fiction event. Okay, first question right out of the gates. Fact or fiction? Next year, myself and our entire panel will be replaced with robots, and all of your questions will be answered by ChatGPT. Of course, I am hoping that the answer to that question is fiction, because this event is so important for us as an opportunity for our experts to share critical information with our wonderful community, and also a chance to thank you for your support of the Dubin Breast Center. Your generosity really makes our work possible so we can continue to deliver the most advanced care possible to everyone who walks through the door. And I couldn't be more excited to say, as you can already see, the event today was completely sold out. Okay, so that's unbelievable. When I told my husband last night that the event was sold out, he looks at me and goes, you know, I bet I could score a couple of tickets on StubHub. I said, maybe so, but they would be more expensive than Taylor Swift concert tickets. So the fact that the event is sold out is a true testimonial to your loyalty and support of our mission at the Dubin Breast Center, and also to all of you to show your intellectual curiosity and sincere desire to learn about and understand the latest breakthroughs and updates related to many, many different aspects of women's health. In particular, of course, I'd like to thank my partner, Eva Dubin. As we like to say, the dog and pony show, where, of course, she always gets to be the pony. She is my partner in this extraordinary endeavor, and because of her continued philanthropy and leadership, the Dubin Breast Center has really become a destination for breast cancer care, not only in the city, but in the country and the world, and we're getting patients coming from all over, knowing that the care that we deliver is exceptional. I think what's really important to note is that what distinguishes us from other places is we don't treat patients with breast cancer, we treat people. And we do treat people regardless of the ability to pay. And that's always been part of our mission, and that's what you're doing today, is help support us in that quest. Thank you. It seems like now more than ever before, particularly post-COVID, there is really no shortage of misinformation out there. And as always, this forum is going to present facts that are based in science. Our panelists are really thrilled to share their expertise and answer your most pressing questions as part of our discussion. So we will open the floor for Q&A, as we always do. But if you're too shy to take the mic, feel free to write it on an index card. We have people circulating around, and they'll pass it to us. I know that it is always tempting. Doctors cannot answer personal questions, or if you start by saying, I have this friend, we're totally on to you, okay? So let's not do that, okay? I am going to ask our panelists to keep their answers on the shorter side so we can get to a lot of topics. I can tell you each of these extraordinary individuals could host a panel to themselves all afternoon, and you would never run out of things to say, but we want to get to a lot of things. And we hope that in the end of the day, you'll take this knowledge and share it with your loved ones so we can help many other women like Suzanne who may embark on a breast cancer journey. With that, I hope you enjoy your lunch. As I introduce our panelists one by one to get the ball rolling, I'm going to start by asking them each introductory question before we open it up. So, our first panelist closest to me, Dr. Amy Tiersten. Dr. Tiersten. As everyone clearly knows, is a highly experienced medical oncologist with an expertise in treating breast cancer and also gynecologic malignancies. She's conducted numerous and led numerous clinical trials and published extensively in the area of breast and ovarian cancer. So our first question, Dr. Tiersten, Let's talk about pregnancy after a breast cancer diagnosis. You just heard the most phenomenal story from Suzanne, who we know you had the honor and privilege of treating. What are the challenges to fertility in women diagnosed with breast cancer? And what can we do proactively to preserve fertility in our patients of childbearing age?
Thanks, Elisa. So one of the most difficult aspects of being diagnosed with breast cancer in women of childbearing age is that frequently, especially in hormone receptor positive breast cancer, which is about 2/3 of all breast cancer, the oncologist turns around and say, you need to take 5 to 10 years of this medication, during which it would be damaging to a fetus and you can't carry a pregnancy. And so, as Suzanne interrupted her anti-estrogen therapy, there finally was a trial confirming the safety of doing this. So, at our last big oncology meeting in December, there was a trial called the POSITIVE trial. Very exciting, 500 women with stage 1 to 3 breast cancer who were 42 or under were permitted to interrupt their anti-estrogen medication after having taken it from somewhere between 18 and 30 months, and they were then given 2 years to conceive, carry a pregnancy, breastfeed, and then go back on anti-estrogen medication. And preliminary results, 4-year follow-up, showed that as compared to historical data, the women who did this did not appear to have a higher risk of recurrence, which was phenomenal. The patients are continuing to be followed, of course. About 75% of the women on the trial had at least one pregnancy during that 2-year period, and there were no negative effects on the children. The other part of this is that chemotherapy in women, especially over the age of 40, has more than a 50% chance of putting women into an early menopause, which is one of the reasons why we advise egg or embryo harvesting. There is medication that we can give during chemotherapy, ovarian suppressive medications known as Zoladex or Lupron, and giving those medication during chemotherapy, putting the ovaries to sleep, because chemotherapy affects rapidly dividing cells. If you put the ovaries to sleep during chemotherapy, you significantly decrease the chances that a woman will go into early menopause and increase the chance of later childbearing. So those are some very important and exciting aspects to this in our field.
Wonderful. Our next panelist, Dr. Christina Welts. She has been a breast surgeon at Mount Sinai and my partner. She's been at Mount Sinai from before I got there for 25 years. She conducts incredible research on anesthesia methods, breast cancer recurrence, and barriers to childbearing in young women with breast cancer. She's won several awards for teaching and directs our Dubin Breast Center Surgery Fellowship Program, through which we are training the next generation of breast surgeons. So Dr. Welts, your first question. What are the newest updates with genetic testing? It seems like every year a new gene pops up. As Suzanne talked about, a gene that some in the audience may not have even heard of. So bring us up to speed and tell us about how genetic testing may affect our cancer patients.
Thank you so much, Elisa. Thanks to everybody for being here. I really appreciate it. Let me touch on a couple of aspects of this question. There's a lot going on currently in the field of breast cancer-related mutations and genetic testing for breast cancer. One issue is simply availability. It wasn't long ago that there was only one lab in the country that was doing genetic testing. They had literally a monopoly. The cost for a woman to get genetic testing was into the thousands, and the results took simply too long. Things have changed now dramatically. There are multiple qualified licensed labs that do genetic testing. The cost has plummeted such that it really is affordable for everyone, even if insurance doesn't pay for it. And the results are coming back much quicker, particularly in women who are getting genetic testing in the context of having just been diagnosed with breast cancer, where you need that information fast to make surgical decision making. So that's been a huge advance. That is translated into the fact that we now do a lot of genetic testing. In fact, the American Society of Breast Surgeons came out with a policy statement in 2019 saying that every woman who's diagnosed with breast cancer and every woman who has a history of breast cancer should undergo genetic testing. So we do a lot of genetic testing at the Dubin Center. There's no question that a lot of the results come back negative. These genes are powerful, but they aren't terribly common. But that's reassuring for the patient. And for the woman, particularly the woman where we didn't expect a genetic test to come back positive, who is found to be a carrier of a BRCA1 or 2 mutation, it can be simply life-changing in terms of knowing the risk, knowing what to do surgically, knowing risk of other cancers. Not to mention their family can be tested, which also proves to be life-saving. The last thing I'm going to talk about is what's called moderate risk mutation, and Suzanne did refer to her carrying the PALB2 mutation. By far, the BRCA1 and 2 are the most common and the most powerful mutations. But now we're starting to learn a lot more about moderate risk mutations, CHEK2, PALB2, CDH1. And with every one of these mutations, we're seeking to learn how common are they, what is the degree of risk that they confer, at what age do they come into play, and all of this informs us in terms of how women should be screened. Should they get MRIs? When should they start screening? Should they consider prophylactic mastectomy, et cetera? And this information is really happening right now. One of the questions that's very relevant to us, Elisa and myself as surgeons in informing our patients, is the difficult to answer question, what is the risk of any of these mutations causing a second breast cancer after you get the first one? We know that about BRCA, but we don't know it yet about these other genes. And that really determines whether a woman should get a lumpectomy versus a bilateral mastectomy, which will protect them against a second breast cancer. To end, we're very fortunate at the Dubin Breast Center that we work with amazing genetic counselors. They're there for the patients, and they teach us all the time as these new developments come out.
Fantastic. Our next panelist is a new addition to our team here. Dr. Galinthia Trotman is the Chief of Pediatric and Adolescent Gynecology, specializing in treating gynecologic patients and problems in our youngest patients with a focus on reducing health disparities. She's developed quality improvement initiatives while providing education and mentorship to medical students, residents, and fellows, and she has published and lectured extensively. So, Dr. Trotman has the distinct privilege of answering the survey question, which you all answered when you registered. So our question that we asked all of you, our survey question was, fact or fiction, birth control pills increase the risk of breast cancer? And I love this one. It's like split down the middle because it means that we asked a good question because a lot of people don't know. 43% answered fact, it's true birth control pills increase the risk of breast cancer, and 57% said no, it's not true. So, Dr. Trotman, in 2 minutes or less, tell us everything we need to know about the risk of oral contraception related to breast cancer, what are the different options, what should we be doing for our young patients in terms of age to start, and you know, just throw in another few facts there at the end. Yeah.
Thank you so much for having me. I'm going to go turbo boost. So the the answer to that question is a little bit loaded. So if we look at the numbers, there is an association between the use of oral contraception and breast cancer. So the relative risk amongst some of the most recent studies do show about a 20% increase, but that's relative risk. What does that mean for each individual's absolute risk is very, very small. So when you look at the numbers, the largest study was in 2017 and evaluated 1.8 million women in the Netherlands. And what they did find is if you use pills for more than a year or any other hormonal contraception, they had a very small increased risk. When you look at that group a little bit further, you see the risk is really related to women who are older. So this risk was not the same for people who started the pills much younger age, as well as after 5 years of use, that risk actually went back down to baseline. When you look at what the numbers really showed, some of the data didn't really make sense to see why would some of the pills cause an increase in breast cancer, as well as some of the lower options, such as the intrauterine devices. So you have to take a closer look at the population. And the studies was flawed in that there wasn't wasn't able to take off the groups really well to see what everyone's individual risk was. So the short answer is yes, maybe, but very, very low risk to each individual's absolute risk remains very, very low. And this does remain the same for people of the highest risk group, people with genetic predispositions as well. And there's many studies to show that. We are at the beginning of this data now because we have 40 years of research. The doses we used traditionally were 150 micrograms. Now we're using as low as 20 or 10. So we do know that the choices we're using these days are much lower. They are going to confer a much different risk and likely a negligible risk at that. Because there are so many other benefits to using contraception, not only for pregnancy prevention, which has its own inherent risks, as well as managing menstrual pain, endometriosis, premenstrual symptoms. There's a lot of comorbidity associated with periods. We do use pills quite often for our younger patients. There are a variety of other options that are available, of which we most often say the estrogen-containing pills or the progesterone-containing pills are some of the most commonly used. There are intrauterine devices, there are patches. They all confer the same risk. So it's really important to know it's not so much about the fact which one do you pick. Any hormonal contraception would have that very minimal absolute risk increase. So that's the short answer to a very big topic.
Thank you so much. That was turbo answer. So our next panelist is Dr. Lori Margulies, well known to many of you. She's the chief of breast imaging at the Dubin Breast Center, and she established our center's multimodality breast imaging division focusing on comprehensive patient care. She's an expert in patient-focused care, advancing new imaging techniques, and even a very unique area, the detection of cardiovascular disease on mammography. She also leads the Mammography VAN program, which provides easy access to breast cancer screening all over the city and in hard-to-reach demographic areas. Dr. Margulies, okay, there are so many recent updates related to imaging to address. In March 2023, new guidelines, maybe many of you heard about this it was all over the news. There were new guidelines on breast density notification that were passed. And then in May, just literally a couple of weeks ago, the United States Prevention Service Task Force updated the recommended age to start mammograms to age 40, down from 50, where they were before, recommending every other year. So just to clarify, we, doctors, have recommended yearly mammograms, every year starting at age 40 all along. And the USPSTF and the American Cancer Society have been flip-flopping like this, okay, making everything very confusing. So how do we make sense of all of these different recommendations? And for your last 30 seconds, if women do need additional imaging due to breast density, how do they decide? Ultrasound, MRI, both?
So I can talk for a half hour, right?
Yeah.
Right? That's okay.
You get the floor.
So thank you for this question. It's actually one of my favorite questions. And you can't make sense of these conflicting guidelines because they don't make sense. So you have the FDA, which is codifying into federal law what New York State and Connecticut and many other states have done, is tell women what their breast density is. It doesn't make sense for the doctors to know but not to tell women, because this is something that we know about you. Why can't you know it about yourself? And why is it important? It's because dense breast tissue not only confers an increased risk of breast cancer, but it makes a mammogram harder to read, so that one may want to avail themselves of supplemental screening. So the FDA gets an A. They finally have got it right. And that goes into effect in September of 2024. The U.S. Preventive Services Task Force, on their hand, gets probably a C-. So finally, they've gone back to beginning screening at age 40 for average risk women. Yay. It makes no sense, however, to make it every other year. If you want to catch breast cancers early, and we know in younger women those cancers are likely to grow faster, why are you going to let them grow for another year? It makes no sense. but everybody in this room can do something about it because you all have books and pens by you. And these guidelines from the Preventive Services Task Force are currently in draft, and they are open for public comment until June 5th. They will listen much more to all of you than they will to me, who they think has a conflict of interest. They don't allow any of us, any gynecologists, any breast surgeons, any breast radiologists, anybody who actually knows anything about breast cancer to be on these panels. That's how they work. So it's important. So in my last few seconds, what I will also say is what they also get wrong is they say there's insufficient evidence to talk about supplemental screening for women with dense breasts, which doesn't make any sense when the FDA just said there is, right? So ultrasound or MRI. MRI is the more sensitive test. If you can get an MRI, if you qualify for it, yay. If not, ultrasound is also very good, doesn't find as many cancers as MRI. But if it's what's accessible to you or if you prefer it, there are benefits and pros and cons to each. But the official recommendation from the ACR, in American College of Radiology, is if you can get an MRI, MRI is the preferred, and that just came out several weeks ago as well.
Thank you, Lori. I want to just add something. You know, in 2016, when the USPSTF reaffirmed these guidelines, I wrote an op-ed along with two other radiologists that was published in the New York Times called Why the Annual Mammogram Matters. And to Lori's point, we were very naive, just wanted to express our views, protect people. We were eviscerated in the comments section. Of course the radiologists recommend mammograms. That's how they make their living. Of course the surgeon wants to detect breast cancer. Otherwise she'll be out of a job. It was incredibly disheartening to me, people who have devoted our lives to the care of women and treatment of women, and we would gladly take early retirement, gladly. And so to Lori's point, I think that you have to understand that there are other ulterior motives coming from the other side, like cost savings, like the paternalistic kind of women get too anxious, they get too histrionic. So until we prioritize lives saved as the be-all, end-all, there are going to be all these conflicting recommendations. Okay, our next panelist, Dr. Jeffrey Mechanic, who is known to many of you. Dr. Mechanic is a world-renowned endocrinologist, and he's authored more than 400 publications in endocrinology, metabolism, nutrition. He's co-edited and co-authored 9 books on the subjects, so something of an authority. Okay, we have to ask the question, the hottest topic around. Ozempic. We're verging off into the women's health and the health. Okay, what do we really know about it? How might it impact overall health? Is there any risk related to breast cancer, and is it sustainable?
Right, well, thanks, Alyssa, and thanks for having me again. This is always a pleasure to come here and speak to this group. So our field of endocrinology has been somewhat bombarded, right, by people who are coming in with a very specific intention just to get a prescription for Ozempic, Wegovy, or Mounjaro. And a lot of this happened because of the media and people who are just flocking to doctors for a term that I had coined maybe about 10 years ago, which is cosmetic endocrinology, right? So, but it's a real thing, you know, and it's unfortunate. It's a patient who will go to the endocrinologist or the doctor, and if it's a male or a female asking for testosterone, asking for DHEA, asking for growth hormone, and now because we have this slew of drugs which have become available by prescription, but they work so well in lowering weight. So Wegovy, you get a median of about 14.9% loss in weight in the year, and now Mounjaro, it's about 22.9% or so loss of weight. So people with normal weights without a medical indication are going and asking for these meds. And let me just give you an apocryphal exemplar of what's going on in the religious Hasidic community. One of my patients told me that when a child is engaged to be married and they have a wedding date, all 4 sets of in-laws will go out and go on Ozempic to get the weight down. So there is this gray market subculture. Now, as a result of it, we are depleted. The supply chain is depleted. So patients with diabetes, patients with obesity now cannot get this drug. The price point has gone up. It's become inaccessible. So when you talk about disparities of care and the socioeconomics and what's fair, it really has pushed the envelope. So let's just talk about it real briefly. Ozempic is glucagon-like peptide 1. It's similar to it. It acts through the receptor. Now, your body makes this. Your body makes this in the intestine. It's a biologic. Your body already makes this compound. And by injecting it, you're raising the levels. It does 3 things. And it's semaglutide is the term. Wegovy is just high-dose semaglutide. Ozempic is FDA approved for diabetes. Wegovy is FDA approved for obesity. Mounjaro is a molecule that interacts with the GLP-1 receptor, but also another receptor, GIP, gastric inhibitory polypeptide or peptide. So these biologics, these chemicals that your body already makes, they do 3 things. 1, they kind of reset the hormones in your body, the insulin and the glucagon, and fat burns off a little bit better. You get less insulin resistance. The second thing is they're part of what's called the ileal brake. When you eat a big meal, right, you go to a buffet, you eat a big meal, there's a lot of food in the stomach, and then the food's going down, it hits the intestine. The intestine's like, whoa, stop. We can't handle so much, and the stomach stops contracting. And there's a brake on gastric emptying, stomach emptying, and it gives you a feeling of fullness. So you'll feel full earlier. That's the second action. The third action is it crosses into the brain and actually interacts with the part of the brain that controls appetite, and it decreases appetite. So it's not just an appetite suppressant, it also affects metabolism, and these medicines work very well. So the question is, should you be taking them? The answer is no, unless you go to the doctor, right? And the doctor does doctor stuff and makes a proper diagnosis, and you really need it, and they have a discussion with you on risks and benefits. The risks are constipation. You can get heartburn because the food's hanging out in the stomach. You lie back, you get some acid reflux. And it's a medicine. All medicines have some side effects. You don't want to just take a medicine willy-nilly. So they're very useful if you need it. So what do you do if you're overweight? What do you do if you have a weight problem? What do you do if you have a chronic metabolic problem? And that's lifestyle medicine. You got to exercise every day. You got to have a plant-based diet. That's not vegan. That's not vegetarian. That means most of the foods you have are plants. And stress reduction, proper sleep, all of those things. That's how you get sustainability. That's why when you read the magazines or the newspapers and you hear that the celebrities go on it, and then as soon as they stop it, the weight goes up. Okay, of course, because they never needed it from the beginning and they didn't adopt a proper lifestyle. So hopefully that answers the question.
Amazing. Any increased risk of cancer with Ozempic? Right.
So there's no direct increased risk of cancer. When the drugs first came out, there was a belief that there may be an increase in pancreatic cancer or pancreatitis. That's been adjudicated, and we've gone through all the data. It's in the guidelines. It does not. But you'll hear about that, and there's a black box warning that if you have pancreatitis or something with the pancreas, not to do it. You'll hear about the thyroid cancer thing and medullary thyroid cancer and MEN. Turns out these were in the mice, right, that were studied. It's not really documented in humans. But the drug company had to negotiate with the FDA to get the drug out sooner. They agreed to the black box warning because they were seeing this statistical signal with medullary thyroid cancer in the mice that were used, not for humans. So we generally don't give it if someone already has a history of multiple endocrine neoplasia or medullary carcinoma of the thyroid. But just because you have thyroid disease, that doesn't prevent you from doing it. But discuss it with your doctor. This is the reason why you see your doctor, and you discuss it with your doctor, and you don't just take it on your own. And there's just to reiterate, there's no direct adverse effect on breast cancer, but there's an indirect protective effect, because if you have overweight, obesity, abnormal adiposity, or you have hyperglycemia, and there's an increased risk for all cancers, then indirectly, yes, it'll decrease the incident risk for breast cancer, and probably by virtue of improving your overall health, will increase your health as a patient with breast cancer.
This is the time you're all waiting for. We're going to open it up to questions. Remember, no, I have this friend. I have lots of other questions that have come up from the audience, so feel free. We have microphones if you want to stand up, but in the meanwhile, we'll go back to Dr. Tiersten, but feel free to stand up when you're ready, or raise your hand when you're ready to ask a question. So Dr. Tiersten, we've heard a lot about one of the newest, most exciting areas of breast cancer is something called immunotherapy. Everyone hears this word, and for people who come into our offices, the first thing they ask us now, these buzzwords, all the buzzwords, is immunotherapy right for me? So tell us what's new in immunotherapy and breast cancer.
So immunotherapy in oncology as a whole has really been a revolution and a very, very exciting, finally coming to fruition of theories over the years. And essentially, breast cancer cells are evil and put out messages to the immune system to shut down the immune system so that the immune system doesn't recognize them as cells that are not supposed to be there. This new category of drugs, which are called checkpoint inhibitors, unleash a patient's own immune system to find and kill the cancer cells using the patient's own immune system, which is amazing. In breast cancer, the role of immunotherapy is limited to a subset of breast cancer, which is called triple-negative breast cancer. These are cancers that don't express the estrogen, progesterone, or HER2 receptor. And studies have shown, initially in patients with advanced metastatic breast cancer, that adding immunotherapy to chemotherapy makes the chemotherapy work much better. But more recently, the way things work in oncology in general is new things are tested in more advanced disease, and if they look promising, they move to earlier stage disease. So for early stage triple-negative breast cancer, it's been shown that adding immunotherapy, frequently with triple-negative breast cancer, I should say, we treat patients with treatment prior to surgery, and there's a variety of reasons for that. So studies have shown that adding immunotherapy to a chemotherapy backbone in patients who are receiving preoperative therapy for triple-negative breast cancer significantly improves outcome and decreases the risk of recurrence. And so it's very exciting to have at least a subset of breast cancer where immunotherapy has an important role.
Wonderful. The next question is going to be to Dr. Welts, turning to a different topic, but a hot one nevertheless. Let's discuss implants. There's so much new information about breast implants. There's a lot of stories that come out intermittently about implants causing breast cancer, implants preventing the detection of breast cancer. What's the newest data, and what do we need to know about breast implants, both for augmentation and for reconstruction?
Implants have been around now for a little more than 60 years, and they've been scrutinized over the decades by the FDA. And overall, their track record as it relates to safety is really good. But needless to say, when something goes wrong, or even if there's a suspicion that something's going wrong, it leads to a lot of exaggeration, misunderstanding, all of the things where we do need to separate fact versus fiction. We doctors and surgeons still get asked a lot about, are implants safe from the point of view of, do they cause breast cancer? Do they make women sick? Do they cause autoimmune diseases, rheumatoid arthritis, scleroderma, lupus? That was the issue that got implants, at least for augmentation, pulled from the market for many, many years, starting in the 1990s. To make a long story short, these questions were thoroughly investigated with really, really well done studies, and the answer is unequivocally no. They do not have those risks. But the most recent thing that you may have heard about is everything in medicine has to have an acronym these days, BIAALCL, which is breast implant associated anaplastic large cell lymphoma. It's an extremely rare thing, but it is a scary thing. What happens is that non-Hodgkin's lymphoma cells can form between the implant and the capsule that the body creates around the implant. And when this occurs, fortunately, it can usually be treated by removing the implant and the entirety of the capsule. But unfortunately, there have also been cases reported whereby the lymphoma becomes systemic. Women need chemotherapy, radiation therapy, and there have been deaths reported. It's really important, though, to keep it in perspective in terms of numbers, as scary as this may sound. There are close to 500,000 breast implants placed per year, most of them for augmentation, and fewer of them, but still about 85,000 for breast reconstruction. So studies looking at this lymphoma have shown that it only occurs in approximately 1 out of 4,000 implant situations. So a scary concept, but nevertheless extraordinarily rare. There's something you'll hear about soon as well, which is somewhat similar, which is squamous cell cancer developing in the capsule that forms in the implant. To my knowledge, the FDA only has 19 reported cases so far, so we'll learn more in time. But by and large, breast implants are very safe.
Amazing. So very few cases in millions. And you know, those cases make headlines, and so it sends everyone on a witch hunt. And as Dr. Welts pointed out, for a long period of time, silicone implants were taken off the market, which did a huge disservice, particularly for women who needed them for reconstruction. And so we're happy that the data prevailed, and we know that they're safe.
Elisa, I should also add that with regard to the lymphoma situation, these cases were largely linked to an implant made by the company Allergan. They were textured implants, which mean they have a rough surface, which plastic surgeons love because they don't slide around so much. But that particular make of implants has been recalled from the market, and that is reassuring.
Great. Okay, moving on. Question from the audience. Yes, in the back.
I'm a patient, Dr. Pierce. Many of my questions over the past year. So my question is for Dr. McCann. You mentioned the benefits of a plant-based diet. I agree with you. I've worked really hard on doing it. I wondered if you had any advice about making sure to get enough protein on a plant-based diet while avoiding dairy.
Is the question about the protein prescription with a plant-based diet? So this is actually a real important issue because most of us, if we eat meat, we get our protein from meat. And when you decide to go onto either a vegan diet or a vegetarian or an overwhelmingly plant-based diet, you really need to keep up with the amount of protein that you take in. So let's address the question just from two ends, and I'll stick to the time. The first is if you're pure vegan, you're going to need to supplement that diet with a protein powder, some protein supplement. You're just probably not going to be able to get in enough. If you were to get in enough, you would have to overeat so much carbohydrate in the beans and lentils and the pulses to get in the amount of protein. You would have to overeat so much carbohydrate that you would need to be in the swimming pool 2 to 3 hours a day doing laps to burn it off. And if you actually know anybody who's a successful long-term vegan, that's what they do. They're actually in the gym burning off all that extra energy from the carbohydrate so they could get the protein in. So you have to find a plant-based protein supplement, soy or one of the others. And then to lesser extent vegetarian and to lesser extent plant-based. But if you're plant-based, you can still have a little bit of animal protein. You're not vegan, you're not vegetarian. But the idea is, my advice would be to see a nutritionist, have the nutritionist go through everything and just make sure you're getting in the requisite amount. But the supplements are probably the answer.
So we have a question for Dr. Trotman. So we all know that longer periods of cycling, right, getting your period at a young age or menopause later can increase one's risk of breast cancer. This is of particular interest because we know and you can verify for us that younger women and even girls are getting their periods now younger and younger, right? We hear stories of girls starting to menstruate even at 8.5 and 9 and so forth. What are the causes of this? What is going on? Is that a real thing? Is it what they're eating? Is it obesity? Is it the hormones in the milk that we're all drinking now? Tell us a little bit about age and onset of menstruation and what we think the causes of that are.
So that's a really, really great question. So what do we know? We know over the last 100 years, the onset of puberty has decreased, but that initially was good, improved nutrition and genetics, so we're having periods around age 12 to 15. What we've seen though in the last 20 years is that the onset of having your first period, which tends to come 2 years after the onset of puberty, has decreased. The onset of the menses has decreased by about 6 months in most age groups, but we are seeing it early and earlier and as early as 8. There are a variety of reasons why truly puberty is happening earlier, and as a result, we're getting earlier menses. Primarily genetic factors. The second part is environmental. There is a big nutritional indication for why young people are having periods earlier. Obesity, that's the number one thing. So the increase in fat cells actually act as a hormone. The onset of puberty is really complex. You have to signal the brain then signals the ovaries. So once you have the turnover from the increased hormones released from the fat cells, the body mistakenly thinks, oh, this is a 10 or 11-year-old, it's time for the body to start churning. So what we do see is we see a lot of young people having early puberty because of that, translating then into early menarche. The second part though, because a lot of our younger people aren't truly overweight or obese, is a lot of the endocrine disruptors. So we see a lot of phytoestrogens, a lot of soy products that we have in food. So I know a lot of the younger patients I see are having their soy lattes a lot. And what those things actually do is they act as an estrogen in the body. So the body sees the soy, or it sees some of the other chemical disruptors, some of the plastics that we use, and it actually binds to the estrogen receptors in the body. And that itself can then trigger the brain to think, okay, it's time for puberty to turn on. So, there's a lot of studies that's being done to kind of tease through, how much of it is genetic, how much of it is environmental. But we do know at face front, just based on obesity, BMI, and a lot of the endocrine disruptors, we do think those are some of the things that are driving the earlier pubertal development that we see that then translates into earlier menarche. We also do have a lot of children with precocious puberty. So precocious puberty is actually puberty in a pathologic age. So anyone that goes through puberty before the age of 8 is someone who has it precocious. And these are the young people that are gonna have their menses very, very early. So you're thinking about 6, 7, or even 8 years old. What are the limitations? Well, we can even think about a lot of the implications of having a period as a 7-year-old. There's psychosocial factors, there's metabolic implications, and it goes really further. It increases the risk of depression and anxiety, but it actually decreases final height. So there are a lot of implications for that, and I usually speak to a lot of my parents about making sure that their young one has an overall package of wellness, right? So you look at their growth charts, you look at their BMI. Are they on the 90th percentile for their height and their weight, and that's where they always are, or are they jumping up? And the time to catch these things is before. So, by the time someone has their period, there's very little that we actually can do. So we always encourage families, pediatricians, to pay attention to what's happening with their body size, breast development, because that's the time we really can use to reverse the clock.
Great. Any questions from the audience? I have a few cards up here. Question right there.
You guys had a lot of good things to say about women who, childbearing years, and that was fantastic. What about for some women who are, as soon as they get breast cancer and things start to happen, they crash. They don't walk gingerly, they crash into hell menopause. Hair starts getting thin, and you start getting, like that refrigerator look, no matter what you do. And so I understand that there's some, hormone replacement therapy that usually helps, that's not available to those women. Do we have anything available for us?
Yes, it's a great question. Thank you for asking it. And fantastic. Because you're right, what we often see is a lot of women come into us diagnosed with breast cancer, And the crash is because not only do we tell them, now you have to stop your hormones that you were enjoying for the last 10 or 20 years, but we're actually going to do the opposite to you, which is after we take you off your hormones, we're going to put you on hormone blockers. It's sort of a double whammy. So people like Dr. Tiersten spend her whole life and all of her waking hours working with patients, trying to mitigate these and work with the person. So I'm going to let her answer that question.
It's a really important topic. Thank you for asking. And it's something that we live through with our patients all the time. Young women going through chemotherapy at the same time that they're having hot flashes and all kinds of side effects of early menopause, early and abrupt menopause. And fortunately, over the last number of years, there have been a lot of studies looking at this. One thing that's been shown to be helpful for hot flashes, for example, is acupuncture. There was a well-designed trial where a third of the women got acupuncture directed toward hot flashes, a third got fake acupuncture, and a third did nothing. And the ones who got real acupuncture had a very significant drop in the frequency and the intensity of the hot flashes. At the Dubin Breast Center, we're going to be starting a trial using a virtual reality frosty environment to see if that helps reduce hot flashes. So it's a very area of important research. And not just the hot flashes, there's issues of vaginal dryness, and we spent a lot of time talking about non-hormonal as well as some safe hormonal lubricants as well. So it's our job as the medical oncologist to ask about these devastating side effects in our patients in whom we're prescribing anti-estrogen medication, as well as patients that we're putting into early menopause with chemotherapy.
And I would say, there's no one size fits all, and we're very, very into pushing the envelope and exploring all the options. For example, as Dr. Tiersten just mentioned, one of the things I think there's a huge misconception about is that topical intravaginal estrogen, specifically for vaginal dryness, does not get a lot of systemic absorption. So there are so many doctors who are misinformed that that's not safe when really it is. And so it's really like getting into the weeds with these questions and asking patients, what are the very specific symptoms? And give us a 1, 2, 3 list of your priorities and what's bothering you the most. And we can address them that way. And that's what these guys spend doing. We've have 2 questions. So shifting away from breast cancer patients, let's talk about patients who do not have breast cancer, but may have a family history of breast cancer. And people want to know about hormone replacement therapy and its safety in women either who do not have breast cancer and have no family history or do have a family history. And how do we advise them about the safety of hormone replacement therapy? Christina and Amy.
We've known for a long time that hormone replacement therapy does increase the risk of breast cancer. And I think you mentioned earlier the concept of birth control pills, for example, being age-related. There are women who stay on birth control pills into their 50s, and you never know if you've gone through menopause because you continue to have regular menstrual cycles, and functionally, physiologically, you may have gone into menopause, and you're still taking these pills, so they're acting as hormone replacement therapy. Newer research that came out in the 90s showed that it was a misconception that you had to be on hormone replacement therapy for a very long time for the risk of breast cancer to kick in. And those studies showed that even if you take it for a year or 2, there is a risk. People started to come off of it. It's one of the reasons that earlier in the 21st century we saw a dip in the risk of getting breast cancer, the rate of getting breast cancer, but they are a risk.
I would just add one thing is that one of the biggest studies looking at this did find that combined estrogen and progesterone definitely do slightly increase the risk of developing breast cancer, but there are some women who can receive estrogen alone who have had a hysterectomy and don't need the progesterone to protect the lining of the uterus from the estrogenic effect of estrogen. And actually taking estrogen without progesterone has been shown to decrease the risk of developing breast cancer.
So again, there's no one size fits all. I want to direct a question to Dr. Margley. Speaking of family history, I think there's a lot of misconception because family history can be such a vast area. You can have a mother who is diagnosed with breast cancer at a very young age and a sister and everyone in your family, or you can have a grandmother diagnosed with breast cancer at age 72 when you have that family history on the other end of the pendulum. Dr. Margulies, how do you decide, how do we figure out what the appropriate screening regimen is for patients with a family history, and how we navigate that and personalize it and customize it so people are have the best chance of picking up breast cancer early, but we're not, over screening them?
That's a really great question, because almost all of us have some kind of a family history of breast cancer. So what we really care about are our really close relatives, our first-degree relatives. So our moms, our sisters, our daughters. If it's your grandmother or your second cousin twice removed, or a bunch of distant cousins, it's not really relevant to your history without those additional mothers, sister, or daughters being affected. So if you have one of those people in your family, if your mom had breast cancer, we heard earlier from Ms. Foote about her mom having breast cancer and passing away. If you have a mom with breast cancer, or if you have a daughter, so 10 years younger when that person is diagnosed is when you want to start screening for breast cancer. So if your mom developed breast cancer at 38, subtract 10 years at 28, that's when you want to start screening. So how to start screening? So do you need to start mammograms at 28? Well, not really. It doesn't really add anything to the MRI screening. So you can put off the mammogram to 35 or 40 and start with yearly MRIs 10 years younger than that first-degree relative. So it's really important to know that family history. So what we now recommend, what the American College of Radiology in its most recent recommendations for high-risk individuals suggest, is that every woman have a risk assessment done at age 25, really, really young. And that's because many women fall through those cracks. They don't think about a family history. They may not realize it. But there are more and more mutations. There are more people who may not realize they have mutations. And something that I will tell everybody in this room that many people don't realize, we think of BRCA mutations as our most dangerous mutation. And we think BRCA, okay, that's an Ashkenazi Jewish person. There are countries in Africa where 14% of those populations have BRCA mutations. So it's not just limited to Ashkenazi Jews. So everybody needs a risk assessment, but particularly Ashkenazi Jewish women and black women in the United States, so that we can start screening earlier, because we know at 40 for average risk women, but maybe 40 is not enough for many women.
I totally agree. And I think it's interesting to know that, just to be clear about the data, in the general population, the risk of a BRCA mutation, if you take 500 women off the street, one will have the BRCA mutation unselected. If you take 40 Ashkenazi Jewish women, one will have the mutation. So 2% of all Ashkenazi Jews carry this mutation. But to Lori's point, there is no ethnic group that's exonerated. There's an Icelandic mutation, there's a Scandinavian mutation, there's an African American mutation. Every single group can be affected. And we don't ever look at someone and say, oh, you're of this ethnic background, you don't need to be tested. One of the biggest challenges, though, is that especially among the Ashkenazi Jewish background, there can be very small families. And so I saw a person, for example, a couple of weeks ago, a 27-year-old with a newly diagnosed breast cancer with no family history. And when you dig deep and start asking the hard questions, these mutations, remember, can be carried down. I always make sure to make this point in every single fact versus fiction lunch. These mutations can be passed down through either a mother or a father's side. Okay, so we can't just interrogate just the mother's side of the family. And then you get into a situation where if the father has no sisters, how do you have a family history, right, when there are so few women in a family, which creates a situation that's called uninformative. So you have to ask, and you have to ask the specific questions about both sides of the family. Okay, this is another good fact versus fiction, which we talk about. What's the truth about deodorant? Must you change to these new ones that claim to be free of, I guess it's aluminum or whatever? Jeff is a health person. Do you know anything about this? We do. Huh? any truth to the matter of harm to general health related to different types of deodorant. And he's looking very scared that I asked him this question. We deal with this all the time, but
Well, I know what I'm going to be reading on when I get back. Not to my knowledge.
So the big myth related to deodorant and breast cancer became when women used like Right Guard and it had these little metal particles, aluminum-based deodorants. We would ask women to wipe it off before having a mammogram, right, Dr. Margulies, because you could see little metal speckles on an x-ray. Somehow that got twisted around in 19 different ways to be translated into this idea that deodorants, especially the metallic-based ones, caused breast cancer, and nothing can be further from the truth. So we don't advise our patients to the specifics. It's, it's dealer's choice. Okay, any other questions from the audience? I have one here that I can ask, right here.
One other thing, corollary to what Dr. Wells and Dr. Christian were talking about with the hormone replacement therapy, we were just talking about, you had said that if you don't have a uterus, estrogen only is fine. It's my understanding that a progesterone-only IUD gives you the progesterone, therefore protects the endometrium, avoiding the systemic increase in risk of the oral progesterone. Is that true or not true?
So the studies looked specifically at the progestin IUD and found the same risk as with the combined OCPs, the same risk, which again gives us a lot of question as to why would that even make sense, which goes back to those studies that found the increased risk may actually be what the individual risk was. But looking at the IUDs, you do have much lower progestin, but you do have systemic absorption, but much, much lower. So it is one of the safest options there.
But, sorry, Lisa, we do generally tell women when they're diagnosed with breast cancer, even if it's not a hormonally based breast cancer, to have a hormone-secreting IUD removed, to stop taking birth control pills, and of course, as we talked about before, to come off of difficult though it is hormone replacement therapy.
I think one of the sidebar conversations about all of this, and I would love to hear Jeff's comments, is there's this whole other class of hormones out there called bioidentical hormones. And I think what's important to know, which I'd like Jeff to expound on, is that this is a huge area of interest in mine because I think it's really a marketing tool. There is this implication that bioidentical hormones gives you all of the benefits and none of the risks. And that's just pure fiction, because if you're getting hormonal, the thing for everyone to know is when you put something in your mouth, whether it's a pill or food or whatever, you don't get to pick and choose where it goes in the body. It gets absorbed by the bloodstream and it goes everywhere. So if they're acting like hormones in various parts of your body, they're acting like hormones, your breasts are seeing that too. And Jeff, maybe you can expound on that relative to bioidentical hormones and also supplements and all kinds of things.
These are not legal words or medical words. These were words that came about from marketing, particularly when a lot of the phytoestrogens from plants like soy and a lot of the supplements came out. There was this marketing attempt to try to push these compounds that were not the pharmaceutical hormones, so they didn't have the side effects, but they had all the benefits that would be on the label. So in 1994, there was legislation called DSHEA, the Dietary Supplement Health and Education Act, and it was passed because it was thought by our wise Congress that one of the reasons why there was so much chronic disease was that it was difficult for our population to purchase dietary supplements. They had to go through a lot of hoops, and we should just make all of them available and not have to go through the FDA and not have to have regulation, et cetera. So there was an explosion of dietary supplements and nutraceuticals. We wrote a guideline on this in 2003. This is the way that I would like you to look at supplements. Are they proven or are they unproven? Divorce yourself from the term of alternative care and complementary care and integrative care. Those words don't mean anything. Are they proven or are they unproven? So just because something is a vitamin, it still is worthwhile. Folic acid when you're pregnant to prevent neural tube defects, vitamin D for osteoporosis. They're vitamins, but there's an evidence base and they're proven. But something like creatine or CoQ10 in order to improve performance. Those things are unproven. And then there are certain supplements that are in various stages. The problem is that when the benefits aren't proven, also the risks aren't proven. So what you're doing is you're dumping a lot of these chemicals into your body. You don't know whether they're interacting with the food. You don't know whether they're interacting with the medicines you're taking. You don't know if they have side effects like ginkgo, ginger, and some of the other ginseng all can cause bleeding, for instance. They can increase bleeding tendencies. So you don't want to flock and just start taking all of these supplements because some naturopath has told you that they're going to help prevent cancer, help you run faster, feel stronger, and sleep better. Again, discuss with your doctor. I'll close with one other comment. There was a study in New England Journal of Medicine, Eisenberg et al. In the late 90s. What percentage of patients fail to disclose the use of dietary supplements to their doctors? What do you think? Yeah, so it's probably not as high as 99. In those papers, it was 60%, but that's still a huge number. That means the doctor is going about prescribing medicines, making diagnoses. There are a lot of patients that come in to see me where ultimately their chief complaint is due to the use, the irrational use of high-dose supplements. And when you stop them, the patients feel a lot better. So we as physicians, we always ask our patients, and you as patients should disclose this to the doctor. Even if you're a little embarrassed, you should still disclose it to your doctor.
I just want to add one thing about soy, which I find to be a very common misconception among patients and doctors alike. And it's such a misconception that it's actually a question on the medical oncology board exam. What about soy in food? And soy in food actually decreases the risk of recurrence of breast cancer. And so many people don't know this, and they're not eating tofu and edamame. And countries like Japan and China, where they eat a lot of soy in their diet, have a much lower incidence of breast cancer. And it's actually been shown that soy in food, not supplements, but soy that's in food is actually good for breast cancer. And one other thing, just to add, about vitamins, there are definite studies that have been done that show that taking vitamins during chemotherapy decrease the effectiveness of chemotherapy.
Right.
Yeah.
Right. Yeah, we have patients who come in all of the time who said, you know, my doctor, I was just diagnosed with breast cancer, and my doctor gave me this immune boosting formula, which, by the way, of course, that doctor is selling to the patient, which is, in my mind, the doctor's version of insider trading. It's, you know, it's predatory. So the doctor gives the patient this immune boosting thing to help them fight their cancer. But meanwhile, they were just diagnosed with cancer, and the cancer is in their body. And the first thing I say to them, I said, you know, you're taking this pill, et cetera, and you're absorbing it. And, you know, how do you know that this cancer isn't just absorbing this stuff and eating it for breakfast? You know, you say it's going to your immune cells, your doctor says it's going to your immune cells, but how do you direct that traffic? Maybe it's just all going to the cancer and it's feeding the cancer. And usually that causes a response like this. Oh my God, I never thought of that. And it makes sense when you say it, but there's just so much out there related to, this is, I think, one of the fundamental functions of this panel related to those areas. I wanted to bring it back. There was a question for Dr. Welts to talk more about what we talked about with Suzanne, which is the genetic testing that can be done in conjunction with fertility, what we call pre-implantation genetic testing. So tell us a little bit about where we are with that.
It really is an area, I think, where medicine approaches the miraculous, extremely exciting. Let me sort of walk you through how it's done. If a woman such as Suzanne, who carries, as she mentioned, the PALB2 mutation, puts women at between a 40 and a 45% risk of getting breast cancer and other cancers, desires to have children, but does not want to pass the mutation down to their progeny. They go through in vitro fertilization. Their eggs are harvested and their eggs are fertilized. And at day 2 to 3 of the life of this tiny little embryo, when it consists of only 8 cells, embryologists who work with fertility doctors can literally pull a cell out of the embryo, extract the DNA from that single cell, and do a methodology called hybridization, where that DNA is put together with the exact gene that that woman has a mutation in, such that you can determine, will this embryo carry the BRCA1 or 2 or PALB2 or whatever gene? And thereby, the embryos that do not carry the gene can be implanted into the mother for pregnancy and childbearing. So this generation to generation passing of genes that are dangerous can be stopped, and it is truly miraculous.
It's really a miracle, and we talk a lot about research and funding, for genetic-related cancers. Well, one of the main ways to do it is to just stop it in its tracks. And BRCA can be ended in 1 generation, or any of the other genes. Any other questions from the audience? I have a couple more here. Lots of cards coming in. Dr. Margulies, talk about AI, as it's a word we hear a lot of related to so many different topics, but it's one area where it's been talked about a lot as it relates to imaging and diagnostic imaging. What's the future, near and far, for AI as it relates to breast cancer screening?
So I think I'll still have a job. So AI is in its infancy. If we think it is analogous to a Model T Ford, our computer scientists would have us think, and the New York Times would have us think that it's going to replace all the radiologists next week. It's not true. So we actually use it for some of our mammograms and some of our ultrasounds. And we find, yeah, sure, it can find cancers. It also misses cancers. It also misses lymphomas. It misses other things that are important. It calls a lot of silly things, like it marks the edges of the paddles. It marks the arterial calcifications. So it's going to be good, but it's not there yet. It's going to definitely help us, and the best radiologists will be those who know how to use it and use it well. So earlier you alluded to my work on breast arterial calcification. So one thing maybe it can do is flag those women who have those calcified arteries in their breasts. And maybe it can automatically, through some chat GPT thing, put something in the lay letter that you get that says, hey, wait a second, you're 45 years old, you have vascular calcifications, maybe you should have a cardiologist or a doctor mechanic or somebody else check them out. But it's not going to find all breast cancers. It's great as a second pair of eyes, great as a second screen. It's going to be the future. And as I said before, the best of us are going to be the ones who know how to use it and aren't afraid of it. It's here. It's finding cancers, it's finding rib fractures, it's finding all kinds of things in every part of radiology, and it's here to stay.
Yeah, you're not retiring before I do, that's for sure. We have a question in the back. Yes. Hi.
I have 2 questions. The first one is, as the mother of daughter approaching childbearing years, I know that when they do genetic screening, when women are pregnant, it's for birth defects. Should women get screened before they want to conceive for all of the cancer tests, and then apply then with that information to what you can do to remove those areas. Prophylactically remove BRCA carrying.
So we'll do this one first. I think it's an amazing question because you have no idea, Elizabeth, how often women come into our office diagnosed with breast cancer who have 2 or 3 children and say, I've already had genetic testing. And it was the exact testing you're describing, which is the prenatal testing to test for transmission of diseases, which is different from the genetic testing panel for cancer predisposition, which we're talking about here. So, Christina, do you want to take that? Because we see these patients all the time.
It's a really interesting idea. You do have to realize, as Elisa said a little bit earlier, that these genes that predispose to breast and ovarian cancer, powerful though they are rare. But I think in an ideal world, and I don't know how ethicists would think about this, it would probably be ideal for every human being in the world, perhaps at birth, but of course you can't consent, to have a blood test to assess for cancer-related mutations, such that at some point in their life when it becomes relevant, they could access this and know where they stand. We are, as I mentioned earlier, doing a lot more genetic testing, but that's really largely limited to women who have breast cancer or who have a highly type of family history that's very, very suggestive of carrying a BRCA gene. The other thing I should add is the methodology that I just spoke about in terms of not passing these genes on does require quite a lot. It requires, not natural conception, but in vitro fertilization. Things can go wrong. You may end up with embryos that all carry the mutation. Such things have been known to happen. But I think we would be in a better place if people knew their breast and other cancer genetic status. I think it would be a good thing. But I know many people would ethically disagree with that concept.
You had another question?
The other question was, you're talking about diet and even here there's a little bit of confusion because you're saying you're going, well, someone who said that you can't have soy milk and lattes, and on the other hand, soy food is perfectly good to eat. So is it the way the soy is processed? Is it the soy milk? And then the other question I have is,
Well, let's do that one first because we got, yeah.
it's also the diet, like free radicals being terrible, and you should eat this and you should eat that. And then I've been told that should be resolved in reverse. So, is there any book people read? Is there any articles that people can go to that really can explain what the current thinking is on nutrition as preventative measure?
Jeff, can you take this? About soy and other healthy diets.
So the question comes up all the time, what's the best resource for healthy nutrition? So number one, obviously discuss with your doctor, but if you really want a resource, I would go to the Dietary Guidelines for Americans, which is on the web, freely accessible. And this is the best evidence-based document that you're gonna see, vetted by the government, vetted by when I served on the President's Council, Science Board, we looked at it, and all the other governmental agencies sort of vet it. So it's DGA, Dietary Guidelines for Americans, and it's every 5 years. And you'll see an executive summary there, and then you can go into detail if you want. It's hundreds of pages or 5 pages for the summary. So that's the answer to your second part. As far as the first part, how do you manage different competing opinions about soy and about free radicals and about fiber and about, all these different things? There's no good food or bad food. Food should be interpreted in terms of dietary patterns. So if you had a diet where 80 to 90% of all the food you ate was coming from a soybean or was soy-based, that's not a healthy diet. We don't need to talk about the individual food, but that's not a healthy dietary pattern. Soy as part of a dietary pattern can be a food that you would incorporate, and it can be part of a healthy dietary pattern. So there's always going to be studies that, particularly in nutritional epidemiology, which is looking at large populations and looking for a statistical signal of whether a particular food or a particular compound is associated with a particular endpoint. And there are a lot of drawbacks from taking those results and generalizing them to a human dietary pattern. The answer, in my opinion, is that a healthy human dietary pattern is one that's plant-based. Most of the foods are plants, high in fiber. Stay away from the processed foods as best as you can, and don't have a lot of fatty food, don't have a lot of sugar, don't have a lot of the things that your mother and your grandmother told you not to eat a lot of. I mean, these are you're not going to have a diet of chocolate chip cookies all day. And at the same time, yeah, I know it sucks, but you're also not going to have a diet where you can never have a chocolate chip cookie. That's not a healthy diet either. So if there's any question, then you meet with a nutritionist or discuss it with your doctor if your doctor feels comfortable going over it. But focusing on one particular food, and be interested to see what the panel has to say, but focusing on one particular food and obsessing over whether one particular food is going to make or break whether you have a healthy dietary pattern, that's the wrong approach. So the answer is yes, you can have soy, and no, soy is probably not going to be bad for you, but also your diet should not be all consuming with soy.
We have time for one more question, and I have a person right here. Maybe one after that. As you can see, we could go on for a very long time here.
If you were tested like 8 to 10 years ago for
Great
BRCA, and now it seems like there are so many new tests, so should we get retested?
Yeah, so I'll take that one. It's a great question. So as you heard, there are so many other genes, and what we're doing is most of these testing, these other genes, were updated in a panel starting in 2013. So most of us, the first thing we do is I ask our patients from before if their testing was performed before 2013, there's a very good chance that their testing should be updated to include this broader panel of genes. And then, of course, people got tested in places that even in 2014 and 15, where they didn't have the wherewithal to do the wider testing. So A, you should find out what you were tested for, and if it was only BRCA1 and BRCA2 even later, yes, you can have your genetic testing panel expanded. Or B, if you were before 2013, then definitely for sure. And last question from over here.
Hi, thank you to all of you for being here. I have a question. What is the latest research on having your ovaries or fallopian tubes removed as a measure to decrease your cancer risk, either recurrence or just cancer in general and postmenopausal?
So two people are going to answer it. We'll have Dr. Trotman answer that for ovarian cancer, and Dr. Tiersten answer that as it relates to breast cancer. Because remember, when we take out the ovaries, we're addressing both the hormonal effects related to breast cancer and the risks related to ovarian cancer. So Dr. Trotman.
So for ovarian cancer, we do know that most of the ovarian cancers originate in the fallopian tube. So we are recommending removal of both the tubes and the ovaries when childbearing is complete in order to reduce that risk. But the tubes universally, so even if women who are wanting tubal ligations now, we're actually removing the tube in entirety, even if we're leaving the ovary.
And as it relates to breast cancer as an option for controlling hormonal secretion.
Right. So about 2/3 of breast cancers are hormonally driven, and a big part of treatment for these cancers is lowering our estrogen blocking medications. For our higher risk early stage breast cancer patients, we do sometimes recommend aromatase inhibitors, which only work in women who are menopausal. And so we can give medications, monthly shots that imitate menopause to allow these women to receive a more effective anti-estrogen medication. An alternative to that is to remove the ovaries and not come to the center and get a shot every month. It hasn't been shown that removing the ovaries is more effective than receiving the shot, but it is an option to make people less tied to the center and to not undergo a painful shot. But it doesn't reduce the risk of breast cancer recurrence more than artificial ovarian suppression.
Do you do the aromatase inhibitors postmenopausally?
So aromatase inhibitors are pretty much the standard of care for invasive breast cancer in postmenopausal women. But some of our higher risk premenopausal women, it's been shown that taking an aromatase inhibitor would be more effective than a medication like tamoxifen in some specific situations. And in those women, we need to suppress the ovaries either surgically or medically to make them able to benefit from an aromatase inhibitor.
So here we are. I can't thank you all enough for coming, for attending, for your incredible questions. I do want to thank my panelists. I want to thank my incredible panelists for sharing their knowledge, and I want to thank our guest, Suzanne, for sharing her story. And to her incredible family, both at home and at work, for coming and supporting her. It means the world to us, and to see who is behind all of our patients, taking them every step of the way. So thank you all. We really, as you can see, we really appreciate the support, so we can continue to help everyone that walks through our doors to fight this deadly disease. And we're committed to offering not only excellent care, but really exceptional care. Thank you all who came and purchased tickets, and who came as guests, who purchased tables. If you have not made a gift and you are so inclined, we would love that and appreciate it. And these pledge cards are at your table. We're so appreciative of your support, and we wish everyone a happy, healthy summer. Thank you so much.